This video talks about lipid-lowering agents. Now, there are about 5 lipid-lowering agents, and all 5 of them work in different places. So, understanding the location of where they start and stop is very important. So, the first drug that I'm going to be talking about are the statins. Okay, the most commonly used lipid-lowering drug is statins. So, let's get right into it. So what statins does is it inhibits HMG-CoA reductase. Okay, before we get into the details, what happens in hepatocytes is that hepatocytes are responsible for making cholesterol in our body. So let's say from glycolysis we get acetyl-CoA. We're going to get about 3 acetyl-CoA. From 3 acetyl-CoA we're going to get HMG-CoA. From HMG-CoA we're going to have mevalonic acid. Okay, from mevalonic acid we are eventually going to get cholesterol. Okay, that cholesterol can be used for many purposes. For example, making vitamin D, let's say bile acids, different things are going to be made with that cholesterol. Point is, this is how cholesterol is made in the hepatocyte. Okay, so the enzyme that it's inhibiting is HMG CoA reductase. So this drug, this statin, is going to inhibit this HMG-CoA. So statin is going to work at that level. So statin is going to inhibit the cell from making mevalonic acid. Okay, and HMG-CoA is going to accumulate, right? Not making cholesterol. So kind of, talking about the whole premise here. Now, what about what effect is it going to have on LDL, on HDL, and TAG? What effect is it going to have? It is the agent that decreases LDL the most. Okay, LDL is going to be radically decreased. TAG is also going to be decreased, not as much as LDL. The radical decrease in LDL is seen with statins. That's why it's such a favorite for someone who is having cholesterol problem. With HDL, LDL is going to decrease, TAG is going to decrease, HDL is going to increase. So see how good of a drug it is. It's not reducing our bad cholesterol, it's also increasing our good ones so that they can clean up the blood vessels a little bit with the HDL. Now that was the clinical use and some of the effects of HMG-CoA. Now let's talk about toxicity. So if you know anything about me, I love my mnemonics, right? So statins really are HMG-CoA reductase inhibitor, right? So there is an H here, there is an H here, and there is an R here, right? So when we're talking about toxicity, what we're going to see is that it's going to cause hepatotoxicity. Okay, we're going to see hepatotoxicity with the H. And with the R, we're going to see rhabdomyolysis. Okay, so these are the two toxicities we're going to see mostly with the statin drug. So some of the tests you're going to see with rhabdomyolysis is going to be you're going to do LFT, right? We're going to do liver function test to see if the toxicity hasn't increased than we want it to. We are also going to see CK increase because of rhabdomyolysis. So that was statins. Now let's move on to niacin. So niacin is also taking place at the same level as statin, that is in the hepatocyte. So let's say niacin, in the hepatocyte we are going to have cholesterol. Cholesterol is going to make VLDL. Okay, it's going to make VLDL. Now this VLDL is going to go in the blood and it's just going to give this VLDL to LDL and all that. Okay, first of all it's going to become IDL, and IDL is going to become LDL. So what niacin is going to do is it is going to inhibit the secretion of VLDL onto the blood. So that is regulation number 1. Regulation number 2 is it's going to inhibit lipolysis. So let's say this is lipolysis. It's going to inhibit lipolysis from the endothelial cells, lipolysis of adipose tissue from the endothelial cells. So this is also inhibited by niacin. So really niacin is working in two spots. One is that it's inhibiting the secretion of VLDL from the hepatocytes and also inhibiting lipolysis from the fatty tissues from the endothelial cells. This is also inhibited by niacin. Now what about toxicity of niacin? So here I use the mnemonic FGH. They kind of, they are in serial, right? FGH. F is followed by G followed by H. Really, there's two H's here. F is for flushing. When you take niacin, it's going to cause a lot of flushing, which can be decreased by taking aspirin. Or by long-term use, you're going to see less and less flushing. So that is the first side effect we see with niacin. Remember also that niacin is a vitamin, right? It makes cofactors. Okay, moving on to G. G is for gout. Niacin does precipitate gout. It also causes hyperglycemia and hyperuricemia. Okay, because of the hyperuricemia, that's why we see the gout as well. So those were the toxicities of niacin use. So one thing I forgot to mention about niacin is what effect is it going to have on LDL, HDL, and TAG. Okay. So since it decreases VLDL secretion, VLDL is going to decrease. So LDL as a result is also going to decrease, right? HDL is going to be increased, just like statins, and TAG is also going to be decreased. So now let's talk about bile acid resins. Okay, so again we're going to start with hepatocyte. In the hepatocyte we have cholesterol, which is going to make bile. Okay, now their bile is made in the liver, stored in the gallbladder. Now this bile is going to be secreted onto the GI tract. Remember, this was the gut. It's going to be secreted onto the GI tract when we're eating food, right? So this secretion of bile happens, but what bile acid resin does, that it inhibits the reabsorption of bile onto the liver. So this is inhibited by bile acid resins. Okay, the reabsorption of bile acid resins are going to be inhibited. The reabsorption of bile is going to be inhibited by bile acid resins. Now, what are some of the examples of bile acid resins? They are cholestyramine and cholestyramine. Okay, these are the one that is going to inhibit reabsorption of the bile. Talking about toxicity, so I'm sure you're not going to be surprised to hear that this is going to cause GI toxicity, is going to cause GI discomfort. Okay, right? Because proper absorption is not happening. They're going to complain about bad taste in mouth, right? They're also going to talk about deficiency of fat soluble vitamins, because if you don't absorb the fat back onto the hepatocyte or onto the blood, you are not absorbing the vitamin that is coming through food, right? And you know that fat soluble vitamins needs to be absorbed with the fat, right? So we can see deficiency of fat soluble vitamins, and we can also see gallstones, because all this cholesterol or all this bile is kind of trapped in the hepatocyte, which is going to get stored in the gallbladder, right, forming stones. So we can also see gallstones with our bile acid resins. Now what about its effect on HDL? It's going to be LDL, HDL, and TAG, right? It is going to decrease LDL because it's not reabsorbing. So if the hepatocyte needs cholesterol, it needs to make it from glucose. Glucose needs to be converted to acetyl-CoA. Acetyl-CoA is going to make cholesterol. Cholesterol is going to make bile. So the body has to make new cholesterol from scratch, which takes some time. So you can see how LDL is going to go up. HDL is going to be slightly increased, and TAG is also going to be slightly increased. So now let's talk about cholesterol absorption blockers. So cholesterol absorption blockers is primarily acting on the GI tract, okay? So it's going to inhibit reabsorption of cholesterol from the food or from gut, whatever. Do differentiate it from bile acid resins, because bile acid resin inhibited reabsorption of bile, okay? Cholesterol absorption blockers is going to inhibit the reabsorption of cholesterol. Some of the examples of cholesterol absorption blockers are, these are the ones that ends with MIB, right? MIB, MIB. So ezetimibe, those kind of drugs is going to be the cholesterol absorption blockers. These drugs is also going to cause some liver problem. So it's routine to do liver function test whenever we are using cholesterol absorption blockers. What's interesting with this one is that, you know, even though this is inhibiting cholesterol, it should have some GI discomfort, but I don't know any, or I don't know any toxicity of cholesterol absorption blockers having GI discomfort, because we do see it with bile acid resin inhibitors, okay? Now, what effect is it going to have on HDL, LDL, and TAG? Okay, it is going to decrease LDL, but it is not going to have any effect on HDL or on TAG. Last but not the least are the fibrates. So the fibrates work at the level of endothelial cells, and they decrease upregulation of lipoprotein lipase. Okay, they're going to decrease the upregulation, and it's going to decrease the lipolysis of the fatty tissues in the endothelial cells. As a result, we're going to see decrease in LDL, okay, really decrease in tags. This is the one which is going to have decreased tag, right? And HDL is going to be slightly increased. Fibrates are also notorious for hepatotoxicity, so we should do liver function tests periodically. And this is also the one responsible for rhabdomyolysis. And which one was the other lipid-lowering drug which also causes rhabdomyolysis? That was statins. Okay, so that's also important.